Hello, Namaste students. Till now we have discussed examination of central nervous system and cardiovascular system examination. So now let us move on to the examination of abdomen, the upper abdomen. So first we'll discuss the symptomatology in the abdominal system. So we'll discuss 4 cardinal symptoms of abdominal system. Pain abdomen is one cardinal symptom of the upper abdomen system. Then you have jaundice. It can be a symptom as well as a sign. Then you have distension of the abdomen, that is ascites is the third symptom, and then GA bleed is the another symptom. These 4 important symptoms we will discuss in abdominal system examination. So students, first we will discuss pain abdomen. Pain abdomen is one of the common symptoms which a patient will approach the doctor. A thorough, detailed, painstaking history is very important in evaluation of the pain abdomen. So first we will discuss what are the causes of the pain abdomen and under what headings it has been divided. So students, first is pain originating in the abdomen. The first category is pain originating within the abdomen. Okay, next. The second category is pain referred from extra-abdominal source. It may be from the cardiothoracic source, genitalia, okay. Then the third heading, metabolic causes, that are usually also known as the medical causes of abdominal pain, as well as neurological causes. Then toxic and uncertain mechanisms. The last 4 categories are usually known as a medical cause of abdominal pain. So, first we'll go what are the causes of pain originating in the abdomen. So here they have been subdivided into parietal peritoneal inflammation pain, then mechanical obstruction of the hollow viscera, vascular disturbance, abdominal wall, distension of the visceral surfaces, then inflammation. These are the subheadings under pain originating within the abdomen. So first we'll take parietal peritoneal inflammation. Students, if the patient has a pain, abdominal pain due to parietal peritoneal inflammation, the pain is steady. Okay, the pain will be steady and constantly aching. Wherever the parietal peritoneum is inflamed, just above the somatic pain patient will be experiencing because of the projection theory of the pain. So steady and aching pain will be there in parietal peritoneal inflammation. What are the causes of parietal peritoneal inflammation? It could be due to bacterial contamination or due to chemical irritation. Bacterial contamination of the peritoneum can occur because of perforated appendix or other any viscus, perforated viscus, or could be due to pelvic inflammatory disease. Chemical irritation can occur due to perforated ulcer, pancreatitis, Mittelmesh. Mittelmesh is painful ovulation. Here the pain depends on the type of the contamination and the amount of the fluid which has contaminated the peritoneum. For example, a gastric acid contamination of the peritoneum is more painful than a fecal contamination by perforated viscera or appendix. Whereas a pancreatic contamination of the peritoneum produces more pain compared to the biliary contamination. The fecal and urinary contamination is usually bland. So it depends upon the type of the contamination, fluid which contaminates the peritoneum and amount of fluid. The parietal peritoneal pain, students, the patient will be still, he hesitate to move because the movement, cough, sneezing and palpation by the examiner increases the pain, unlike a colicky pain where the patient will be thrashing in the bed. Okay. So Parietal peritoneal inflammation, if it is there, the patient tries to lie still. One more important feature of pain from the parietal peritoneal inflammation is guarding. The muscles overlying the parietal peritoneal inflammation will undergo guarding rigidity. Muscle spasm will occur. But there are some conditions where spasm may not occur in spite of parietal peritoneal inflammation. In a retrocecal appendix, or if the rupture is occur into the lesser sac, in a psychiatric patient, up-to-date patient, and immunosuppressed patients, there may not be any rigidity or the guarding in spite of peritoneal inflammation. In a perforated appendix and a pelvic inflammatory disease, initially the pain may be a little dull aching pain. Later, when the bacteria grows, inflammatory mediators are increased, pain may worsen. So these are the causes of parietal peritoneal inflammation, students. Perforated appendix or perforated viscous, pelvic inflammatory disease, both are bacterial contamination. Chemical irritation, ulcer, it's the gastric acid. Pancreatitis, the enzymes. Middle mush, the painful ovulation. The next study is mechanical obstruction of the hollow viscera. Here, patient will have a colicky abdominal pain, the mechanical obstruction of the hollow viscera. They will be tossing in the bed. If there is a small intestinal obstruction, the pain will be around the umbilical region. If there is a large intestinal obstruction, there will be infraumbilical pain. The obstruction of the biliary tract, sometimes or most of the times it may not produce colicky pain. There may be only a dull aching constant pain. So it's a misnomer, biliary colic usually. The obstruction of the pancreatic duct by any tumor also produces a pain similar to that of a biliary tree pain, but the pain of pancreatic duct dilatation will relieve by sitting and leaning forward and increases on recumbency position. Then obstruction of if there is a bladder distension, produces a dull aching suprapubic pain. If the intravesical part of the ureter is obstructed, patient will have pain in the genitalia, testis, and inner aspect of the thigh. If the pelvic ureter junction is obstructed, patient will have pain in the renal angle, costovertebral junction, backside, renal angle. And in any other part of the ureter, if it is there, the pain will radiate from loin to groin region. So, bladder pain, the ureteric pain, along with non-specific abdominal pain and appendicitis pain are one of the common causes of abdominal pain. So, non-specific abdominal pain, appendicitis pain, and this pain due to ureter and bladder are one of the commonest cause of abdominal pain. So next is pain due to vascular disturbances. Here in pain due to vascular disturbances, the patient will have pain out of proportion to the signs. Usually there won't be any signs, there is no rigidity, there is no guarding. A constant pain without guarding or rigidity is a feature of vascular disturbance. Can be embolism or thrombosis of supramesenteric artery. Could be a vascular rupture, abdominal aortic rupture can occur where the pain will radiate to the sacral region, back. Or there can be a pressure on the artery or torsional occlusion on the artery, sickle cell anemia. These are the causes of vascular disturbance. Sickle cell crisis, they can have abdominal pain. Next is abdominal wall. There can be a distortion or traction of the mesentery. Trauma or infection of the muscle, myositis, can produce abdominal wall pain. Of late, because of the extensive use of anticoagulants, rectal sheath hematoma is one of the cause of abdominal wall cause pain. We had one patient cerebellar infarction. We had given a high molecular weight heparin because she couldn't afford low molecular weight heparin. After third or fourth day, she developed abdominal pain. Then when you get ultrasound scan done, it was showing rectal sheath hematoma. So incidence of rectal sheath hematoma is increasing in the era of anticoagulation. So the next heading is distension of the visceral surfaces by hemorrhage. Hepatic and renal capsules will get distended due to the hemorrhage, so they can have pain. Then inflammation, appendicitis, typhoid fever, and nephritis can produce abdominal pain due to pain originating within the abdomen. So what are the headings, students? Parietal peritoneal inflammation, mechanical obstruction to the hollow viscera, vascular causes, abdominal wall, distension of visceral surfaces by hemorrhage, and inflammation. These are the causes of pain originating within the abdomen. Next. Pain referred from the extra-abdominal source. So it can be referred from the thoracic or testis. So what are the causes? Cardiothoracic causes. Myocardial infarction pain can radiate to the abdomen. Myocarditis, endocarditis, pericarditis, congestive heart failure, pneumonia, especially lower lobe pneumonias, pulmonary embolism, pleurodynia, tension pneumothorax, empyema, and esophageal diseases including spasm, rupture, or inflammation. Then genitalia, torsion of the testes. So here the pain can be referred to the abdomen. One important feature of the pain referred from the other sources to the abdomen is these referred pain from the thoracic causes will reduce with taking deep inspiration. Whereas if the pain is from the abdominal cause, pain will increase both with inspiration and expiration. Pain from the referred causes will reduce with inspiration. And even on palpation. On palpation, if the pain is due to the referred causes, wherever area, abdominal area where it is referring, there if you palpate, the pain doesn't increase. In fact, it may reduce. Now the metabolic causes. Diabetes, diabetic ketoacidosis, they can have abdominal pain, one of the medical cause of abdominal pain. Uremia, hyperlipidemia can cause pancreatitis and they can have pain. Hyperparathyroidism, adrenal insufficiency, porphyria. Porphyria and lead both will produce increased peristalsis, which you may confuse with the intestinal obstruction. Both porphyria and lead toxicity can produce peristalsis, hyperperistalsis of the intestine. You may confuse with the intestinal obstruction. Angioneurotic edema, C1 esterase inhibitor deficiencies. These are the metabolic causes of abdominal pain. Then neurological pain or psychiatric causes. Herpes zoster, as I discussed, one of the case of chest pain. A zoster infection can have a pain, abdominal pain in a dermatomal distribution. Tape dorsalis, diabetic crisis, if there is a gastric crisis with a muscle rigidity, if you palpate, the pain will reduce in the neurological cause of tape dorsalis. If you palpate the abdomen, the pain will reduce, unlike parietal inflammation pain. Causalgia or radiculitis, spinal cord or inner root compression. Then functional disorder, one of the commonest cause of late of the more incidence of irritable bowel syndrome, of functional disorder, IBS. Then psychiatric conditions. Toxic causes, lead poison, insect or animal envenomation, black spider widow, snake bite. And uncertain mechanisms, narcotic withdrawal and heat stroke. These are the causes of abdominal pain, students. Now, after enumerating some characteristics of these causes of abdominal pain, let us go back. What you should ask in the history after knowing all these causes. In the history, what are the points you have to focus and ask the patient? So, in the history, these points, age of the patient, because some of the cause of abdominal pain comes in older age group due to atherosclerosis, for example, superior mesenteric artery occlusion. malignancies. Time and mode of onset of pain. For example, abdominal aortic aneurysm rupture, there will be sudden onset of pain, which peaks initially only intensity. Pain characteristics, the type of pain, colicky pain or a dull, aching, constant pain of parietal peritoneal inflammation or a colicky pain of a hollow viscous obstruction. Pain characteristics, duration of symptom, acute or chronic like in say pancreas. Location of pain and site of radiation. For example, cholecystitis, the pain will be right hypochondric radiating to the shoulder and scapula. Pancreatic pain will radiate to the back. Aortic aneurysm rupture will radiate to the sacral region. Then associated symptoms like nausea, emesis, anorexia, diarrhea, constipation you have to ask. Then menstrual history, a painful ovulation, the Mittelbush. These are some of the key points you ask in the patient history. The general physical examination. What are the examination points you will see while patient in abdominal pain? So eliciting the guarding is a cruel method because the patient will have a lot of pain. Instead of that, you can do a gentle percussion or ask the patient to cough for eliciting the rebound tenderness. Rebound tenderness, as I told, is a feature of peritonitis. Then auscultatory sounds, absent bowel sounds is seen in peritonitis, paralytic ileus, whereas increased bowel sounds is a feature of intestinal obstruction. Any abdominal pain patients, you have to do per rectal examination, students, because in some of the conditions they'll have only per rectal pain on examination but not abdominal findings or abdominal pain. The conditions some where PR may be painful is diverticulitis, twisted ovarian cyst, sometimes appendix, ruptured appendix. Only PR examination will give a clue. So this is how you approach a case of abdominal pain. Next, we'll go to the discussion of jaundice. Students, one of the common symptoms of abdominal system is jaundice. If a patient recognizes it and if he approaches a doctor, it is a symptom, or sometimes a doctor may recognize, then it is a sign. In the first part of jaundice, today we'll have detailed discussion about jaundice. In the first part of jaundice, we'll have the definition, production metabolism of bilirubin, measurement of serum bilirubin and measurement of urine bilirubin. So what is jaundice? Jaundice is the yellowish discoloration of the body due to deposition of the bilirubin. The tissue deposition of bilirubin occurs in the presence of serum hyperbilirubinemia and is a sign of either liver dysfunction or hemolytic disorder or disorder of bilirubin metabolism like inherited metabolic bilirubin disorders are there. Either of these three conditions will increase the bilirubin and there will be tissue deposition. Then how much bilirubin is there, you can estimate roughly by physical examination. What part of the body, palms, body involved, what percentage, which part of the body is involved, you can measure it. The degree of serum bilirubin elevation. The first part in the body to get discolored is the sclera because it has high affinities because of elastin content to the bilirubin. So if a scleral tissue is discolored, then the serum bilirubin level is around 3 milligrams per deciliter. Apart from sclera, the other part which you can examine for jaundice is below the tongue. And even palate you can examine for jaundice. Once bilirubin rises, the skin eventually becomes yellow and in long-standing case it may become green. The green color is due to oxidation of bilirubin to biliverdin. Another sensitive indicator is patient may complain yellowish discoloration of the urine. When it occurs, it is only due to excretion of conjugated bilirubin. Conjugated bilirubin is water soluble, that will be excreted, but not the unconjugated bilirubin in the urine. So here the patient often describes the urine as a dark color, tea or cola colored. If urine is showing the bilirubinuria is there, then it is due to elevation of the direct fraction of the bilirubin. And therefore, the problem is either in the liver or biliary tract. It is usually the obstruction. Any jaundice should be differentiated from the other conditions like carotenemia, excess use of drugs like quinacrine, and exposure to phenols. Carotenemia occurs in high consumption of vegetables, oranges. Carotenemia body will be yellow colored but sclera will be spared. That is how we distinguish carotenemia from a jaundice. Now let us go on to the production metabolism of bilirubin. Bilirubin is a breakdown product of heme. You have hemoglobin that will be breakdown into heme and globin. Bilirubin is a breakdown product of heme. How it is produced we will discuss now. About 80 to 85% of the bilirubin, which is 250 to 300 mg of bilirubin, is produced by breakdown of hemoglobin in the reticuloendothelial cells like spleen and liver. The remainder comes from bone marrow because of the prematurely destroyed cells or other hemoproteins like myoglobin and cytochromes in the body. Formation of bilirubin occurs mainly in reticuloendothelial cells like spleen and liver. So the first reaction, students, heme will be acted by heme oxygenase. It will convert that into biliverdin. That is the first reaction. This occurs in a microsomal system, microsomal enzyme, heme oxygenase. Then the second reaction occurs in the cytosol. It is a cytosolic enzyme. Biliverdin will be converted by biliverdin reductase into bilirubin. The bilirubin now, which is formed in the reticuloendothelial cells, is not soluble in the water, but it has to be transported in blood. So to transport in the blood, it must be solubilized. How? The solubilization will occur by binding to albumin. So this unconjugated bilirubin, which is bind to the albumin, will goes to the liver. In the liver, albumin is not taken up. Only bilirubin will be taken up by the liver, but not the albumin. By carrier-mediated membrane transport, only bilirubin is taken up by the liver, but not the albumin. Then after entering the hepatocytes, the unconjugated bilirubin will bind to a number of proteins called glutathione transferase superfamily. This binding of the bilirubin to glutathione transferase superfamily prevents the efflux of bilirubin from the liver back to the blood. Then in the endoplasmic reticulum, this bilirubin will be conjugated to glucuronic acid. This conjugation of the bilirubin with the glucuronic acid is done by UDP glucuronase transferase in the endoplasmic reticulum of the liver. Now, this bilirubin which is conjugated is hydrophilic, it is water soluble. From the endoplasmic reticulum, it diffuses to canalicular membrane by multidrug resistant protein 2, MRP2, into the biliary canalicle. A portion of the bilirubin enters the sinusoid and portal circulation by MRP3, and a portion can be reuptake by the hepatocytes by these two proteins, the albumin organic anion transport proteins, OATP1B1, OATP1B3. So this conjugated bilirubin in the liver, which diffuses to biliary canaliculae, will enter the duodenum, and then it just passes unchanged through the small bowel. This conjugated bilirubin is not absorbed by the small intestine due to its hydrophilicity and increased molecular size. But in the distal ileum and colon, it is hydrolyzed to unconjugated bilirubin by the bacterial beta glucuronodases. So this conjugated bilirubin will be broken down to unconjugated bilirubin by the bacterial enzymes. So this unconjugated bilirubin is reduced by the normal gut bacteria into urobilinogen, 80 to 90% of these urobilinogen will be excreted, stercobilinogen and urobilinogen. That is why you get yellow colors to the stools. And some of the urobilinogen will be absorbed by the portal circulation back to the liver, and some of the urobilinogen will be excreted in the urine. So this is the metabolism of bilirubin, students. Detailed metabolism of bilirubin. Okay, the same thing. 10 to 20% enters the hepatic circulation. A portion exceeds in the urine. Now, biochemically, how do you measure the serum bilirubin? Serum bilirubin is measured by Van de Berg reaction. First, the bilirubin is exposed to sulfonilic acid without the addition of alcohol. So, how much part of the bilirubin which will react with the sulfonilic acid without alcohol is direct fraction. See, direct fraction is that which reacts with sulfonilic acid in the absence of an accelerator such as an alcohol. Then you will add alcohol. Then how much amount of bilirubin which reacts is the total serum bilirubin. So without alcohol, just sulfonilic acid is the direct. Then with alcohol is the total. Then you subtract direct from the total, you get the indirect bilirubin. So this is how you measure by Van de Berg reaction. So by this estimation, the bilirubin comes around 0.1 to 1.2 total bilirubin, and conjugated is 0 to 0.2. One more is delta bilirubin, where the conjugated bilirubin will attach to the albumin. This delta bilirubin is the reason why jaundice may persist even if clinically the patient improves, because of the half-life of the albumin is more. That is the explanation for the persistence of jaundice even if clinical improvement is there, because of the long half-life of albumin. So you can measure the urine bilirubin also. The unconjugated bilirubin doesn't excrete it in the urine, you cannot measure that, but the conjugated bilirubin filters are the glomeruli. Okay, and that you can measure it. Now, this is the basics of the bilirubin metabolism and the measurement. Now, what are the cause of isolated elevation of the bilirubin? In the evaluation of jaundice, it is mainly divided into the diseases which produce only bilirubin elevation. Liver enzymes will be normal, SGOT, SGPT, alkaline phosphatase. Then other scenarios where along with bilirubin, liver enzymes will be abnormal. Depending upon the liver enzymes abnormal, it can be hepatocellular or cholestatic. Hepatocellular, where amino transferases will be more, SGOT and SGPT. Cholestatic, where alkaline phosphatase will be more. So students, first we'll consider isolated elevation of bilirubin, where liver enzymes are normal. Liver is not affected. SGOT, SGPT, alkaline phosphatase is normal. Only bilirubin is elevated. What are the conditions? Hemolytic disorders. Unconjugated bilirubinemias. Hemolytic, all the hemolytic disorders, inherited and microangiopathic hemolytic anemia. Inherited spherocytosis, sickle cell anemia, thalassemia, pyruvate kinase enzyme deficiency, G6PD deficiencies. Acquired microangiopathic hemolytic anemia, PNH, spore cell anemia, parasitic infections like malaria, cobalamin deficiencies, immune hemolysis. So, a list of hemolytic disorders. Let us not go detail about these hemolytic disorders, which we will discuss in anemia. But they produce, bilirubin will be elevated, only isolated. In these hemolytic disorders, the bilirubin rarely exceeds 5 milligrams. But higher levels you may get if there is associated hepatocellular dysfunction or acute hemolysis crisis like sickle cell anemias. Ineffective erythropoiesis occurs in cobalamin iron deficiency. Resorption of hematoma and massive blood transfusion also results in increased hemoglobin and overproduction of bilirubin. Then there are some drugs like rifampicin and probenecid where they inhibit the uptake of bilirubin by the liver. So conjugation doesn't occur. There will be an unconjugated hyperbilirubinemias because of the uptake problem by the rifampicin and probenecid. Then There may be improper conjugation itself within the liver. What are those diseases? Crigler-Najjar syndrome, where there is severe deficiency of glucuronase transferase enzyme. Bilirubin can extend till 20 and death can occur because of complete absence of UDP glucuronase transferase activity. And Crigler-Najjar type 2 is a mild variety where patient can survive till adulthood. Here there is a reduced activity of UDP glucuronase transferase. This is defective conjugation. Then Gilbert syndrome, where there is a defective conjugation as well as the uptake of the bilirubin by the liver. Usually mild hyperbilirubinemia around 6, seen in males. Incidence is around 5 to 10%. In stress, fasting, fever, this bilirubin may increase in Gilbert syndrome. Students, in all these conditions only bilirubin is elevated but not the liver enzymes, remember. Then till now what I discussed is only unconjugated bilirubin was more, but there are some conditions where only conjugated bilirubin will be more. Conjugation is occurring in the liver, but liver other pathology is not there. That is why SGOT, SGPT, alkaline phosphatase will be normal, but the conjugated bilirubin is not excreted into the biliary canaliculi, it is diffusing back, producing a conjugated hyperbilirubinemia. Dubin-Johnson syndrome, because of mutation of gene MR2, Rotorua syndrome. These two are the syndromes where there is conjugated hyperbilirubinemia. These two are not very serious conditions, so don't have to worry too much about these two syndromes. So, a table depicting what are the cause of isolated hyperbilirubinemias. Indirect, as I discussed, hemolytic anemia, ineffective erythropoiesis, increased bilirubin production by massive blood transfusion, resorption of hematoma. Drugs which inhibit the uptake of bilirubin, rifampicin, probenecid, ribavirin, protease inhibitors like atazanavir, indinavir. And where there is defective conjugation, like inherited conditions like Crigler-Najjar type 1 and 2 and Gilbert syndrome. These are the indirect bilirubin will be elevated. Which are the conditions where direct bilirubin will be elevated? Dubin-Johnson syndrome, Rotorua syndrome. Students, here SGOT, SGPT, alkaline phosphatase will be normal. So just see this chart. Here you see in the left side isolated elevation of the bilirubin, that is indirect hyperbilirubinemia. If the direct is less than 15, then that is indirect. Causes are rifampicin, probenecid because of the defective uptake. Then defective conjugation by Gilbert syndrome and Crigler-Najjar syndrome. Then overproduction of bilirubin by hemolytic disorders and ineffective erythropoiesis. If there is a direct hyperbilirubinemia, then you think of Dubin-Johnson and Rotorua syndrome. Students, for the time being, let us worry about only this portion of this diagram. I will come back to this diagram again while explaining the hepatocellular and cholestatic jaundice. For the time being, you worry only on the left side of the chart in this. And here also in this chart, students, evaluation of a chronically abnormal liver function test. Liver function test, if there is only bilirubin elevation, then fractionate it. If it is direct, indirect. If it is direct, Dubin-Johnson syndrome, Rotorua syndrome. If it is indirect, that is less than 15% direct, then evaluate for the hemolysis. If the workup is negative, it is Gilbert syndrome. If workup is positive, it is hemolysis. Okay? Let us worry about only this part of the graph. I will come back to these things later. Now, how do you approach for the other cause of jaundice where there is an elevation of the liver enzymes? This I will come back to this chart. So, any initial step in the evaluation of jaundice is to order the blood where you will estimate the bilirubin level, then take the proper history, interpret the history, and also here the bilirubin, when you see when it has an isolated bilirubin elevation, it comes either because of overproduction of bilirubin or impaired conjugation of the bilirubin or regurgitation of the conjugated or unconjugated bilirubin back from the hepatocytes into the blood. So the first step is whether bilirubinemia is predominantly conjugated or unconjugated, whether other biochemical liver tests are abnormal. I'll come back to this when other biochemical liver test abnormal, how to interpret it. So then history you have to ask medication and drug exposure, because so many medications and other over-counted drugs and herbal medicines can damage the liver, producing hepatocellular and cholestatic pattern. Then physical examination you have to do, lab test, bilirubin, then liver enzymes, alkaline phosphatase, then SGOT, SGPT. This is SGPT, this is SGOT. Alanine aminotransferase, aspartate aminotransferase. Then prothrombin time and albumin, you have to measure it. History, you have to take a complete history, ask about the drugs, because drugs can produce hepatitis, chemical exposure can damage the liver, or herbal and vitamins can damage the liver. Parenteral exposure, because the viruses hepatitis B, C, transfusion hepatitis B and C can damage the liver. IV drug abusers can develop hepatitis B, C. Tattooing hepatitis B and C. Sexual activity, exposure to contaminated blood, these all can produce viral hepatitis. Alcohol consumption, alcoholic hepatitis. Then if they have arthralgia, myalgia, weight loss and abdominal pain, fever, you think of autoimmune hepatitis and viral hepatitis. That is hepatitis A. Then if jaundice is there with sudden onset of right hypochondriac pain, chills, Charcot striate, that is ascending cholangitis. So physical examination, you will see whether any temporal proximal muscle wasting, which indicates either cirrhosis or pancreatic cancer. All the stigmata of chronic liver disease, alcoholic liver disease and chronic liver disease, you have to see spider navy, palmar edema, gynecomastia, caput medusae, Dupuytren's contracture, pyruvate enlargement, testicular atrophy, which are seen in advanced alcoholic liver disease. If there is an enlarged left supraclavicular lymph node, it suggests abdominal malignancy. JVP can be seen in a right heart failure, which can produce congestive hepatomegaly and jaundice, cardiac jaundice, cirrhosis. You can have a pleural effusion in ascites in advanced liver cell cirrhosis. So look for the size of the liver and whether ascites is present. Nodular liver can be seen in cirrhosis and malignancy. Tender liver, viral hepatitis, alcoholic hepatitis. Murphy's sign, cholecystitis, Murphy's sign. Then ascites in the presence of jaundice could be due to cirrhosis or malignancy with the peritoneal spread. Now, after physical examination, how to interpret the laboratory test? As I told here, you will measure the bilirubin level, then liver enzymes, alanine and aspartate transferase, alkaline phosphatase, albumin and prothrombin time. So these liver enzymes help in distinguishing between hepatocellular and cholestatic pattern. Patients with hepatocellular conditions generally present with a rise in aminotransferases to that of alkaline phosphatase. If there is a hepatocellular problem, liver damage, aminotransferases will be more compared to alkaline phosphatases. Whereas if a patient has a cholestatic conditions, then alkaline phosphatase will be more compared to aminotransferases. So patient should undergo albumin level and prothrombin time estimation, because low albumin suggests cirrhosis or malignancy. And increased prothrombin time indicates vitamin K deficiency, either due to prolonged jaundice or malabsorption of vitamin K. And failure of prothrombin time to correct with the vitamin K indicates there is a severe hepatocellular problem. Because for absorption of vitamin K, you need proper bile constituents. So that's why a prolonged jaundice can produce malabsorption of vitamin K, which can increase the prothrombin time. So students, now let us go to which are the hepatocellular conditions which can produce jaundice. So here the liver parenchyma is damaged and aminotransferases are more than alkaline phosphatases here. The infections, viral hepatitis, it could be A, B, C, D and E. They are called hepatotropic viruses. But there are other viruses like Epstein-Barr virus, cytomegalo, herpes can produce jaundice and hepatocellular jaundice. Alcoholic hepatitis, Drug toxicity. The predictable dose-dependent drugs like acetaminophen or unpredictable idiosyncratic reaction like INH. Environmental toxins, vinyl chloride, then Jamaica bush, kawa, mushrooms, Amansia phalotes, Verna, then one metabolic disease, intermediary metabolism disease, Wilson disease can produce hepatocellular jaundice. Then autoimmune hepatitis in females, middle-aged females, where there's joint pain and involving the liver parenchyma. So students, mainly viral infection, drugs, toxins. Wilson disease, autoimmune hepatitis. These are the one which produces hepatocellular condition producing the jaundice. So Wilson disease occurs in young patients. Ceruloplasmin is a screening test for Wilson disease. Autoimmune hepatitis seen in the middle-aged females, and ANA will be positive. You can do SMA and liver kidney antibody also. One thing is in alcoholic hepatitis is the AST to ALT ratio will be more. In the other condition of hepatocellular conditions, the ALT is more than the AST, but in alcoholic hepatitis, AST is more than the ALT. Whereas in viral hepatitis and toxins, ALT value is greater than AST. Patient if he has a jaundice with cirrhosis, usually there is only a slight or a normal elevation of the aminotransferases level. So in these hepatocellular conditions producing jaundice, you have to send for the investigations like hepatitis A virus IgM antibody, hepatitis B surface antigen, then IgM antibody to the core hepatitis B, then hepatitis C virus RNA level you have to send it. Drug induced, there can be a dose fixed, predictable like acetaminophen producing hepatotoxicity, unpredictable like idiosyncratic reaction like INH. So that is about hepatocellular conditions. Now students, which are the cholestatic conditions which can produce jaundice? See, cholestasis can occur at two levels. One is intrahepatic or extrahepatic. It is very difficult to distinguish between intrahepatic from extrahepatic clinically and examination and biochemical parameters. So ultrasound should be done. Ultrasound can detect intrahepatic or extrahepatic. If biliary radicals are dilated, it is extrahepatic. If biliary radicals are not dilated, it is intrahepatic cholestasis. See, absence of biliary dilatation suggests intrahepatic. Presence of biliary dilatation suggests extrahepatic. After doing ultrasound, you have to do a CT scan, MRCP and ERCP and endoscopic ultrasound, further investigation to find the cause of obstruction where it is. So what are the cause of cholestasis jaundice? Students, the causes which produce hepatocellular jaundice also produces even cholestatic jaundice also, like the viral, toxins, drugs. Especially they produce intrahepatic cholestasis. So same conditions, intrahepatic cholestasis, a viral hepatitis B, C, hepatitis A, Epstein-Barr virus, cytomegalovirus, alcoholic hepatitis, drug toxicity, pure cholestasis by anabolic and contraceptive steroids, cholestatic hepatitis by chlorpromazine and erythromycin acetylate, chronic cholestasis by chlorpromazine and prochlorperazine. There is one entity known as primary biliary cirrhosis seen in females with intractable itching and pruritus. This intrahepatic cholestasis will be there. Primary sclerosing cholangitis, vanishing bile duct syndrome, then inherited conditions like progressive familial intrahepatic cholestasis and benign recurrent cholestasis. These are all rare conditions producing intrahepatic cholestasis. Again, some of the rare conditions: cholestasis of pregnancy, total parenteral nutrition, non-hepatobiliary sepsis, postoperative cholestasis, paraneoplastic syndrome, veno-occlusive disease, graft versus host disease, infiltration disease, especially in India like tuberculosis, and infectious causes in India like malaria and leptospirosis can produce hepatocellular intrahepatic cholestasis, malaria, leptospirosis, dengue fever, typhoid. one of the most common cause of jaundice in a developing country like India. So these are all about intrahepatic cholestasis. Now what investigation you do, and later we'll go for extrahepatic cholestasis. The gold standard for cholelithiasis is ERCP. Endoscopic ultrasound, it can detect the bile duct obstruction. And those who have intrahepatic cholestasis, you can do a serological testing for the virus etiology plus a biopsy for like primary biliary cirrhosis. Drugs producing intrahepatic cholestasis, if you be told, it is reversible, like anabolic steroids, contraceptive steroids, chlorpromazine. Primary biliary cirrhosis is an autoimmune disorder. See, as I told, it comes in middle-aged females with an intractable itching. Primary sclerosing cholangitis is characterized by destruction and fibrosis of the bile ducts, vanishing bile duct syndrome, where the bile duct, there will be a bile ductopenia, decrease in the number of bile ducts. And two inherited conditions, familial intrahepatic cholestasis, benign intrahepatic cholestasis, and cholestasis of pregnancy. So, which are the extrahepatic cholestasis? Outside the liver, where biliary radicals are dilated, usually classified under malignant and benign conditions. So, malignant are cholangiocarcinoma, pancreatic carcinoma, gallbladder carcinoma, periampullary carcinoma, and malignant involvement of the porta hepatis lymph nodes. Benign cholelithiasis, postoperative biliary strictures, primary sclerosing cholangitis, chronic pancreatitis, AIDS cholangiopathy, Mersey's syndrome. Mersey's syndrome is a hepatic duct obstruction by the stones present in the gallbladder neck. Mersey's syndrome, and parasitic disease like Ascaris. So mainly you remember like a malignant and benign conditions in extrahepatic conditions producing the jaundice. Cholestasis, extrahepatic condition producing the cholestatic pattern. Cholelithiasis is the most common extrahepatic cause of jaundice. And cholecystitis can put ascending cholangitis can have a jaundice, sepsis, and circulatory collapse. There is one more new entity, IgG4 associated cholangitis. In the developing countries, the common cause of jaundice is drugs and extrahepatic obstructions. Whereas in a developing country like India, infections are the most common cause of jaundice. Like malaria, leptospirosis, dengue, typhoid. Now students, let us come back to this algorithm. This we have discussed isolated elevation of the bilirubin. Okay. Now let us go this side. Bilirubin with other liver enzymes elevated. It could be hepatocellular or cholestatic. So hepatocellular means ALT and AST will be elevated out of proportion to alkaline phosphatase. Then go to all the condition of hepatocellular pattern which I discussed in the table 45.2 in the Harrison 20th edition. So which are all the etiology? Viral etiologies like hepatitis A, B, C and toxins, and Wilson disease, ceruloplasmin. Then autoimmune hepatitis, ANA, smooth muscle antibody. These you will estimate in a hepatocellular condition. If results are negative, then other viruses estimation you will do like cytomegalovirus, Epstein-Barr virus, hepatitis D, E. If still negative, then go for a biopsy. Hepatocellular condition, mainly virus, toxins, autoimmune hepatitis, Wilson disease. After all the antibody estimation and results are negative, go for a biopsy. Next here, cholestatic pattern. So cholestatic pattern, here alkaline phosphatase is out of proportion to ALT and AST. Then go to all the conditions which are told in the table 45.3, cholestatic condition. It could be intrahepatic cholestasis, extrahepatic cholestasis. How to make out? Ultrasound. If biliary ducts are dilated, it is extrahepatic cholestasis. Do MRCP, ERCP, RCT. If ducts are not dilated, it is intrahepatic cholestasis. Then again, all the viral etiologies, antimitochondrial antibody because of primary biliary cirrhosis, then the drugs and toxins, you will review it. If results are negative, do a biopsy. If AMA is positive, again you should do a biopsy for confirmation of primary biliary cirrhosis. So simple, students, it is a logical way of assessing the jaundice. Okay, then come back to this graph again. We have discussed about this side, the elevation of the bilirubin, isolated elevation of the bilirubin, the evaluation of chronically abnormal liver function test. Now let us see what happens if there is a cholestatic pattern. Sorry, yes, the second one, hepatocellular pattern. Hepatocellular pattern is alkaline phosphatase will be less, SGOT, SGPT will be more. So you see the drugs, viral etiology BC, iron and TIBC for hemochromatosis, ANA for autoimmune hepatitis, ceruloplasmin for Wilson disease. Then if workup is negative, then celiac disease, another non-hepatite condition you will think, and then still workup is negative, you will do a liver biopsy. And here cholestatic pattern, you will review the drugs, do the ultrasound here because alkaline phosphatase will be more than AST and ALT. Ducts dilated, it is extrahepatic, do MRCP, ERCP, CT. If ducts are not dilated, then check AMA. AMA if negative, then you do a liver biopsy, it is intrahepatic cholestasis. Then here also all this can produce intrahepatic cholestasis, the viral and drugs etiology. If only alkaline phosphatase is elevated, isolated elevation, then if along with the GGT and 5-nucleotide is elevated, this alkaline phosphatase which is elevated is due to the liver, or else this elevated alkaline phosphatase is due to the bone from bone. It could be due to bone or liver. If GGT and nucleotide is also elevated, it is due to the liver. If only alkaline phosphatase is elevated without GGT and 5-nucleotide, it is bone. So then you do ultrasound, do AMA and liver biopsy to evaluate the etiology. Okay, students, that is a use as a battery these liver function tests in the evaluation of jaundice. So this is about jaundice. So next we'll discuss about ascites, students. Namaste, students. Till now we have discussed two important symptoms of abdominal system, the abdominal pain and then jaundice. Let us go to the another important symptom of abdominal system, that is abdominal distension, especially because of fluid, that is ascites. What are the causes of diffuse distension of abdomen, students? You know the famous mnemonic which you will be taught from the third term. The 5 F's, of late one more F is added, the fetal growth. Which are the F's? Flatus, fluid, feces, fetus and fetal growth. Fat. Of all these things, the fluid is the one which is very important, and that is called as ascites. Today we will discuss about ascites. Ascites could be due to the cirrhosis or non-cirrhotic causes. First we will discuss the pathophysiology of the ascites due to the cirrhotic causes. Next we will discuss the pathophysiology of the ascites in non-cirrhotic causes. The pathophysiology of the ascites due to cirrhotic causes is mainly due to, in cirrhosis there will be a fibrosis of the liver parenchyma, so there will be obstruction to the portal blood flow. There will be a stellate cell hyperactivation producing the fibrosis, the second etiology, and the endothelium of the cirrhotic liver produces less nitric oxide, producing vasoconstriction within the liver. But contrary, the systemic nitric oxide will be overproduced, producing the vasodilatation expression in the splanchnic circulation. So intrahepatic nitric oxide is less synthesized, so there will be a vasoconstriction. Whereas the extrahepatic nitric oxide is over-synthesized, so there will be a splanchnic vasodilatation, and then there will be a pooling of the fluid. This splanchnic accumulation of the fluid, blood, will produce decreased effective circulatory volume. This decreased effective circulatory volume will stimulate, as we discussed in the edema chapter, three things. Increases the AVP. AVP will increase the absorption of sodium and water from the distal convoluted tubules and collecting ducts. Renin-angiotensin system will get activated. So more aldosterone, more sodium and water retention. Then there will be increased sympathetic nervous system activation. So all these will produce edema formation in cirrhosis patients. What is the mechanism in non-cirrhotic causes? For example, if there is a malignancy, peritoneal malignancy, tuberculosis or pancreatitis. In a malignancy, peritoneal malignancy, there is a more protein exudation, secretion by the metastasis. The same mechanism will act in tubercular peritonitis, where there is a more protein exudation into the abdominal cavity. Whereas in pancreatitis, the pancreatic juice will be secreted into the peritoneal cavity. So these are the causes of ascites in non-cirrhotic. This is the mechanism of ascites in non-cirrhotic causes. What are the cause of ascites? 84% of the cases, the cause of ascites is cirrhosis of liver. In another 10%, it could be a mixed carcinomatosis, tuberculosis, pancreatitis, hypothyroidism, renal failure. They constitute the other percentage. The most common cause of ascites is cirrhosis. How do you approach a case of ascites? That one investigation which is a cornerstone in ascites evaluation is paracentesis. Abdominal paracentesis should be done from the left side flank region. Because of the more depth of the ascites and thin abdominal wall, the left side is preferred. And abdominal paracentesis is a relatively safe procedure. The risk of hematoma, infection, hypotension and hepatorenal syndrome is less. It is safe even in the presence of coagulopathy. What are the things you look in the ascitic fluid gross examination? It can be a milky, if there is a more triglyceride, hypertriglyceridemia more than 1000 milligrams. The cause of this hypertriglyceridemia and chylus, you get in tumor, tuberculosis, trauma, congenital anomaly and cirrhosis, the chylus ascites. The fluid gross appearance could be brown in biliary leak, or it could be black in pancreatic necrosis or malignant melanoma. This is the gross appearance of the fluid. What are the other investigations you send in ascitic fluid analysis? You will send protein, sugar, cell type, cell count, and to diagnose tuberculosis, ADA, smear, culture you can send. Nowadays CBNAT. One important investigation which will be helpful in ascitic evaluation is SAG. Serum ascites albumin gradient, SAG. Suppose the serum is 4 and ascites is 3, then SAG is 1, 4 minus 3. Serum ascites albumin gradient. So depending upon the SAG gradient, it has been classified into SAG more than 1.1, SAG less than 1.1. SAG more than 1.1 is a transudate, SAG less than 1.1 is a exudate. What are the cause of exudative cause of ascites? SAG less than 1.1. Biliary leak, nephrotic syndrome, though it is a transudate, in that SAG will be less than 1.1, it is the exception, nephrotic syndrome. Pancreatitis, peritoneal carcinomatosis, tuberculosis. SAG more than 1.1 is transudate. Again, in SAG more than 1.1, you can subdivide into, based on the ascitic protein quantity, ascitic protein less than 2.5, ascitic protein more than 2.5. So SAG more than 1.1 with ascitic protein less than 2.5, you get in cirrhosis, late Buchiari and massive liver metastasis. Here, why you get ascitic protein in these conditions less than 2.5? In these conditions, the damage to the liver is so much that the sinusoids are destroyed so much that the proteins cannot leak into the peritoneal cavity. It cannot come back to the peritoneal cavity. That is why here it is less than 2.5. In cirrhosis, late Buchiari syndrome and massive liver metastasis. Whereas SAG more than 1.1 with ascitic protein more than 2.5, you get in hepatic failure or constrictive pericarditis, early Buchiari, infravenical obstruction, sinusoidal obstruction syndrome. Here, the damage to sinusoids is not that much, so protein can seep back to the peritoneal cavity. This is how a SAG helps in the evaluation of ascites. Then, how to distinguish a primary bacterial peritonitis, spontaneous bacterial peritonitis, from a secondary bacterial peritonitis from the ascitic fluid analysis. A spontaneous bacterial peritonitis is usually due to one organism like a E. coli because of the seepage of the bacteria from the gut lumen into the peritoneal cavity. Whereas a secondary bacterial peritonitis, it is a polymicrobial, multiple organisms will be there due to rupture of the viscus. Ascitic fluid glucose will be less than 50 in a secondary bacterial peritonitis. Ascitic fluid LDH will be more than a serum LDH in a secondary bacterial peritonitis. So, three differences: polymicrobial, glucose less than 40 and LDH more than the serum LDH is a secondary bacterial peritonitis. Then how do you treat ascites? The treatment of ascites is salt restriction, diuretics, especially aldosterone antagonist, spironolactone. You can give a loop diuretic, but the ratio, the maximum dosage you can give the spironolactone is 400 milligram. A loop diuretic is 160 milligram. If still the ascites is not controlled with 400 milligrams of spironolactone and 160 milligram of loop diuretic, it is called as resistant ascites. Resistant ascites can be managed with alpha blocker like midodrine. Then you have to do a large volume paracentesis and TIPS. A large volume paracentesis should be accompanied by albumin infusion 6 to 8 grams per liter of fluid removed. If it is a malignant ascites, then you do a peritoneal vein caval shunt. Beta blockers you should not give in a resistant ascites because the mortality is increased in the resistant ascites if you give beta blockers, though it reduces the incidence of bleeding, esophageal varices. This is how you treat ascites. What are the complications of ascites? Ascites can produce spontaneous bacterial peritonitis. The definition is polymorphonucleosides more than 250 with the clinical features like pain abdomen or a fever, or polymorphonucleosides more than 500 even without the clinical features. The organism is usually E. coli, and as I told you, to distinguish spontaneous bacterial peritonitis from a secondary bacterial peritonitis from a viscous rupture. The treatment is a third generation cephalosporin for 5 days. In a malignant ascites, the incidence of spontaneous bacterial peritonitis is very rare. Diuretics will increase the opsonine content within the ascitic fluid, reduces the incidence of spontaneous bacterial peritonitis. Then under some scenario, you give prophylaxis to prevent the SBP. Which are the scenarios you give the drugs to prevent the SBPs? A previous incidence of SBP. If the ascitic fluid is less than 1 gram or esophageal variceal bleeding, then you have to give prophylactically the antibiotic norfloxacin every day to prevent SBP. So this is the brief discussion of ascites, students. One is first is the pathophysiology in cirrhosis, pathophysiology, non-cirrhotic causes. Then the causes of cirrhosis. Then abdominal paracentesis, how the gross appearance will look, what are the investigations you send, and the next important thing is SAG, more than 1.1, less than 1.1. Then how do you treat ascites? Then the complication of ascites, that is SBP. So all the information about the symptomatology which I gave today, the abdominal pain, the jaundice and ascites as taken from 20th edition Harrison. I acknowledge just 20th edition Harrison's. So tomorrow we'll discuss one more important abdominal symptom, that is GA bleed. Along with that, we'll go ahead with the examination of abdominal system, students. Hello students, namaste. Till now we have discussed in abdominal system the symptomatology. We discussed yesterday the symptoms abdominal pain, jaundice, ascites. Today we will discuss about GA bleed, another important symptom in abdominal symptomatology. So GA symptoms, students, has been mainly classified. It can be overt GA bleeding or it can be occult GA bleeding. The overt GA bleeding can occur like hematemesis, a melena or hematochezia, whereas occult GA bleeding will manifest like anemia. Whenever the patient has symptoms of tiredness and routine blood checkup done, he may be having anemia. That may be giving it loose, he may be losing the blood in the GA tract. So GA bleeding can be upper GA bleeding or lower GA bleeding. What are the causes of upper GA bleeding? Upper GA bleeding causes are bleeding peptic ulcer, esophageal variceal bleeding, erosions, the gastric erosions, then erosive esophagitis, tumors of the stomach, vascular ectasias, then unknown source. So I repeat, the cause of upper GA bleeding are bleeding peptic ulcer, esophageal variceal bleeding, erosive gastritis, erosive esophageal gastritis, erosive esophagitis, tumors of the stomach, and unknown source, then vascular ectasias. First, let us discuss about bleeding peptic ulcer. Peptic ulcer by endoscopy has been classified by different morphology into whether they are more prone, they are more serious, or they can be discharged depending upon the morphology. The ulcers have been classified into active bleeding may be occurring while doing endoscopy. There may be adherent clot, or there may be a non-bleeding but visible vessel in the ulcer. Ulcer is not bleeding, but there may be a visible vessel. These three are very dangerous bleeding peptic ulcers where they are more prone for occurrence of the bleeding. The other two are clean based ulcer and a pigmented ulcer, flat pigmentation, and a clean based ulcer. These two are not a serious cause of bleeding peptic ulcer. 1/3 of the peptic ulcers will have the recurrence again bleeding if treated conservatively. The adherent clot, bleeding peptic ulcer, and a visible vessel, these three should be kept in the hospital. These three categories of patients should be kept in the hospital for at least 3 days because the maximal recurrence of the bleeding will occur within the 3 days. The clean based ulcer and the pigmented flat ulcer, the risk of rebleeding is very less. To prevent the recurrence of the bleeding, the three are important causes of recurrence of the bleeding: NSAID use, H. pylori, and acid. So if possible, NSAID should be stopped, but If NSAID has to be taken, if it is a must, use COX-2 inhibitor along with proton pump inhibitors. Then H. pylori should be treated. If H. pylori and NSAIDs are not the cause for the recurrence bleeding, then acid suppression should be done continuously. While treating the serious cause of ulcers like a bleeding peptic ulcer, active bleeding which is occurring, adherent clot, or a bleeding vessel, non-bleeding ulcer but a bleeding vessel you can make out. In these three categories, a high dose of pantoprazole infusion is known to decrease the mortality, decrease the recurrence of the bleeding, and it stabilizes the clot. Most of the recurrent bleeding occurs within 1 to 2 years. So this is about bleeding peptic ulcer. Next is esophageal variceal bleeding. Esophageal variceal bleeding can be a massive, it can be life-threatening. Both the medical and banding combination therapy is superior to either of the treatment used alone. Esophageal variceal banding is the treatment of choice, but even you have to give medical line of management octreotide 50 microgram infusion, then 50 microgram hourly for 2 to 5 days. If patient is in child C category 11 to 13, if the score is there, tips should be done, transjugular intrahepatic portosystemic shunt. To prevent the recurrence of the bleeding, both banding and beta blockers is superior to either used alone to prevent the recurrence of the bleeding. If patient continues to have bleeding in spite of beta blocker and banding, then you have to do transjugular intrahepatic portosystemic shunt in esophageal variceal bleeding. Next is Mallory syndrome. After a bout of alcohol with vomiting and retching, there can be a tear in the gastroesophageal mucosa, especially on the gastric side, and a patient can have hematemesis. Mallory syndrome 80 to 90% heals spontaneously. Another 10% requires endoscopic therapy. Angiography and surgical therapy are very rarely required in Mallory syndrome. Next is erosive gastritis. Erosive gastritis can be due to alcohol intake, NSAID usage, or stress. Stress because patient is having an intracranial trauma, intracranial bleed, ICU on mechanical ventilation, more than 1/3 of the burns if the body is having, coagulopathy, sepsis, major surgery. These are all stress to the body. At that time they can develop these erosions. Gastric erosions are not that a very serious cause of bleeding, like a variceal bleeding or a bleeding peptic ulcer. Then other cause of upper GI bleed can be malignancy, vascular ectasias called watermelon stomach if there is a vascular ectasias in the gastric antrum, Delophoidus lesion where a visible submucosal vessel can produce a bleeding, hemobilious, the blood into the biliary tract, hemosuccus pancreatitis where bleeding can occur in the pancreatic duct. These are the other rare causes of bleeding, upper GI bleeding. What are the causes of bleeding from small intestine? Bleeding from small intestine, the causes are tumor, Meckel's diverticulum, NSAID use, or Crohn's disease. So I repeat, bleeding from the small intestine could be due to a tumor, Meckel's diverticulum, NSAID use, or Crohn's disease. What are the causes of bleeding from the colon, the lower GI bleeding? Colon, all of you know, commonest cause of a colon bleed is hemorrhoids, fissure in ano, diverticulitis, CA colon, occult bleeding can occur, they can present with anemia, old age people, CA colon. Then colitis, colitis could be due to infection, inflammation, or inflammatory bowel diseases like Crohn's disease, ulcerative colitis. Then post-polypectomy, it can produce bleeding. The diverticular bleeding will occur from the right colon. It is profuse, painless, and it is more. Diverticular bleeding presenting like occult bleeding is very rare, and chronic bleeding is very rare. So I repeat, the cause of colonic bleeding are hemorrhoids, fissure in ano, CA colon, vascular ectasias, post-polypectomy, colitis, infectious, inflammatory, ischemic colitis. These are the causes of lower GI bleed from the colon. So students, how do you distinguish upper GI bleed from a lower GI bleed? Upper GI bleed will have melena. Melena is a dark colored, maroon colored stool which is offensive and very difficult to wash from the pan, and it sticks to the pan. Melena occurs anywhere bleeding above the level of ligament of teeth. To occur melena, the blood should be in the GI tract for at least 14 hours, or as long as 3 to 5 days, the blood may be there in the GI tract. If the bleeding is very brisk from upper GI bleed, hematochezia may be there because you don't have time to mix with HCl to produce melena. Hematochezia is a feature of lower GI bleed, frank red color blood from the lower GI tract. It is hematochezia, where not brown color, no offensive smell, easily washable. Another important thing in upper GI bleed is there is hyperperistalsis movement of the GI tract, and there is increased blood urea nitrogen to serum creatinine ratio in upper GI bleed. So melena is upper GI bleed, hematochezia is lower GI bleed. Increased peristaltic movement, increased blood urea nitrogen to serum creatinine in upper GI bleed. How do you approach and manage a case of GI bleed? So let us go to this. So here, students, ulcer can be active bleeding or a visible vessel. Both are dangerous. Adherent clot, this is also dangerous. A flat pigmented spot and clean base is not that much dangerous. So these are the endoscopic features here. If it is an active bleeding or a visible vessel, then you have to do endoscopic therapy. Then you have to give intense pantoprazole infusion therapy. Then diet, clear liquids you have to give, only liquids for 2 days. Then hospital they have to stay for 3 days. Active bleeding or a visible vessel. If there is an adherent clot, here also they require endoscopic therapy. This is also dangerous. And intensive PPA therapy you have to give here. Diet you have to give clear liquids for 2 days. Then they also should stay hospital 3 days. In both this flat pigmented spot and clean based ulcer, endoscopic therapy is not required. Only conventional PPA therapy once a daily is enough. No need of intensive PPA therapy in flat pigmented spot and clean base. So flat pigmented spot, clear liquid for 1 day and then hospital for 1 to 2 days and you can discharge. Clean based ulcer, regular diet, hot diet also they can, normal diet they can take, and you can discharge without admitting. Just after endoscopy you can discharge a clean based ulcer. Okay, so intensive PPA therapy and endoscopic therapy for the serious cause like active bleeding and visible vessel and adherent clot. No endoscopic therapy, only conventional PPA therapy, and only 1 day hospital for flat pigmented spot, discharge for clean base without admission. Esophageal variceal bleeding, you have to do endoscopic band ligation, then octreotide drug you have to give, both because the combination therapy is beneficial. Liquid for 2 days and hospital for 3 to 5 days, esophageal variceal bleeding. So banding plus octreotide. For malarivis, if there is an active bleeding, endoscopic therapy, then antiemetics, clear fluid for 1 to 2 days, hospital admission for 1 to 2 days and then discharge. If no active bleeding, No need of endoscopic therapy, give antiemetics, can take regular diet, and you can discharge after endoscopy. For maladies. And if there is erosion, gastric erosions, no endoscopic therapy, just once a day PPA therapy, normal diet, and you can discharge after endoscopy. So students, this is how you manage an ulcer, esophageal variceal bleeding, malarial tear, and erosions. Next we'll go, how do you manage a lower GI bleed? So whether patient is having hemodynamic instability or no hemodynamic instability matters. If there is no hemodynamic instability, age is less than 40 years, you can just do sigmoidoscopy. If less than 40 years, if no hemodynamic instability, colonoscopy is required if there is a family history of colon cancer or iron deficiency anemia. But more than 40 years lower GI bleeding, you have to do colonoscopy. So in the colonoscopy, if the site is identified, bleeding stops, it's okay. If site is identified, bleeding persists, then you have to do angiography, and then if bleeding persists, then surgery. If site is not identified, then you have to do a workup for an obscure bleeding site. I will tell what you will do for obscure bleeding site. For obscure bleeding site, you will do angiography and capsule based endoscopy, video capsule endoscopy for obscure bleeding. If there is a hemodynamic instability, you have to do upper endoscopy. And if there is hemodynamic instability, if no upper GI scope, if you can prepare the patient for colonoscopy, go ahead with colonoscopy. If too unstable for preparation, then you have to do angiography. If still persists after angiography, instability persists, do a surgery. Okay? With the intraoperative endoscopy, you can do the surgery. This is how you manage a colonoscopy. So, no hemodynamic instability, less than 40 sigmoidoscopy. No hemodynamic instability, more than 40 years colonoscopy. After colonoscopy, still site is not identified, you can go ahead with the angiogram and surgery and obscure bleeding workup. If hemodynamic instability, do upper endoscopy also along with that colonoscopy. If able to prepare, if not able to give the preparations, then angiogram, then surgery. This is how you approach and manage the case of lower GI bleeding. So students, we discussed the 4 important symptoms of abdominal system: abdominal pain, jaundice, ascites, and GI bleed. So next we'll go with the examination of the patient. Thank you.